Hi, Dr. Lance Trexler here, and also
Laura Trexler. Hello.
So, good afternoon. It's good to be with our VR colleagues again. So we've got a lot of content planned for today, and I see we've got a number of folks on here. I guess I've got a question first of all, and that is, how many new people do we have? I know there's been a number of new counselors join VR in the recent months, and so I'm just kind of curious, how many of you are new with VR, or is this your first webinar regarding brain injury and the resource facilitation? If you would maybe fire a chat comment out, that'd be great, so we just know how many new people we've got. Hi, Cheryl Connor. Where are you located, Cheryl? And Cecilia, I see you're on here. Good. That's certainly, you're an experienced TBI specialist person, so it's good to see you there. So I guess there's nobody else other than Cheryl that's new. Well, I don't know, maybe it says multiple attendees are typing. So, okay, we have, I'm sorry, I don't know your it looks like Etheridge. So, hi, and Cheryl, you're from Vanderburgh County. Okay, great. And Christina Blankenship is on. Okay, great. Wendy Waldman is on. Lovely. Hi, Wendy. Okay, Cheryl, so you're not new to VR, but new as a TBI specialist. Thank you. Linda Brown from Huntingburg. Great. And then Denise Loring is typing something that I'll bet we're going to see in a second here. Oh, hi. Good afternoon. And I see, Fred, you're on. Good. Thank you for participating. And Sandy Wiedner, Tina Lambert. Great. Well, thanks for just sharing with us who's on. The other thing I'd like to do is, as I said, we've got a variety of content, but I would like to also, if you would comment about what kind of questions or what kind of things you would like to hear about today. I know a couple of you gave some input to Wendy, and we did our best to incorporate that, but I want to make sure that we cover today any questions or comments that you might have. So please feel free to fire those out in the chat room also, so that we can address them today. We're going to get back on schedule now in terms of doing these webinars quarterly. And if we don't get to some of them today, we can certainly get to them in the future. And of course, you can always email Laura or me with questions at any time about anything. So it's not exclusive to doing webinars. So yeah, if you have questions or comments or things you'd like to see addressed today, please let us know. So what we thought we would do today, since we've rolled out the resource facilitation services throughout a pretty substantial sector of the state, and some of you have had the opportunity to start now using the service since we did that spring rollout. We wanted to spend some time going over the initial evaluation in particular today, and focus on that, so that we can get into details and questions about that you may have. I will jump to the end of the presentation and share some exciting news with you, and that is that we are getting ready to roll out now services from Bloomington down to Evansville covering the entire southwest of the state. And that rollout will occur somewhere in the next 2 to 3 months. Is my, it may be sooner than that, but more than likely in the next 2 to 3 months. And information will be coming from VR leadership about that in the pretty near future in terms of how we get that going. But that's we're working on getting this out statewide as quickly as possible. So I'll dive in here and start off. And again, please raise questions as they come up for you. This can be more of a conversation than it is a lecture. Oh, somebody's got their... make sure to mute your phone. We're getting some feedback here from somebody, if you don't mind. And Sandy, thank you for chatting in. Sandy has got a comment here. When hiring for a new TBI, is there an online guide or an archived webinar or something like that where we can direct a new TBI, vocational rehabilitation counselor, so they can do some independent learning? There is a whole bunch of stuff, Sandy. We've got a great number of resources in that respect.
This is Laura. I'm just jumping in to offer some supplemental information. I was reminded by Wendy Waldman this morning that the training that we did in March, all of that has been recorded, and that information is going to be provided to VR leadership so that they can disseminate that to new members.
That was video recorded too, wasn't it?
It was video and audio recorded.
Yeah.
And it's all on DVD, so...
Yeah, so they can certainly get access to that because we did, as you may recall, Sandy, a fairly extensive training program there. And then also, please email Laura or me because we can send you, I don't know if you have a copy of our best practices manual for resource facilitation, but we'll be happy to disseminate that. And if anybody wants that, of course, just email us. So yeah.
And then, of course, we have some documents that we utilized when we first launched resource facilitation. So there's really quite a variety of documents that describe what we do. And as Lance said, you can email Lance or I, and we'd be happy to send you what we have electronically.
And they're also great for your insomnia management. You'll be asleep instantly. So, and of course, I'm going to give you Laura's email, which is laura.trexler, Laura.trexler @rhin.com. And mine is the same, except lance.trexler. So if you guys want to email us, feel free to do so. So thanks for the question, Sandy. Okay, so let's get into the initial evaluation. The first thing I wanted to spend a little bit of time on is just the conceptual framework. Why did we structure this evaluation like we did? And there's a variety of reasons why we did, but to back up here a second, as we've discussed in some previous webinars, return to work after brain injury, we feel is different because of the very nature of the injury and the cognitive and the neurobehavioral problems that these folks have make it a fundamentally different process of getting these folks back to work. And so the very nature of the diagnosis is what makes it a challenge. And it also requires, therefore, a different conceptual framework, a different approach than someone who has an intact learning, memory, problem-solving, cognitive apparatus. So I would just kind of want to walk through this. Some of you have seen this before. This first part a little bit anyway, but the return to work outcomes, typically when you look at most published studies, is somewhere between 20 and 35%. And that's really crummy in terms of vocational outcome for people with brain injury. And one of the most salient reasons that those outcomes are so bad is because of discontinuity. And this image I've always liked because it's really hard to get across to return to work if there's these huge gaps in the continuum and gaps in our systems. So this is the problem. And some of you have seen this before, but so I'll briefly go over it, but some of you haven't. The issue with brain injury is it's not a static condition, and it's not it's not a recovery process that is predictable in many respects. You can predict it within limits if you gather a lot of data, and you know the recovery research. But what this graph shows is these are recovery lines for a number of subjects with TBI, and each line represents an individual and their level of functioning on a particular test. And so I know that if I do something here, I can draw. No, that's not what I want to do. Okay, maybe that's it. There we go. So each now, well, we'll see. I'm going to play with this. So each one of these lines is an individual, and their level of performance on this test is over here. So it's kind of like IQ scores, 130, 100 is average, etc. And they administered this test immediately after injury, at 6 months after injury, at 12 months after injury, and 60 months after injury, or 5 years later. And when I first saw this, I was immediately taken by the fact that the recovery process was nonlinear. That is, you've got people that get worse for 6 months, make some progress at 12, but it takes them 5 years to get back to where they were right after injury. Here's a person that starts off at not too far off of average, but doesn't make any progress whatsoever for a year, and then progressively declines. Here's a person that declines for the first year, and then makes progress for the next 4. And so you see all kinds of variation in the course of recovery, number one, and number two, it's always not for the better. In fact, sometimes these patients clearly get worse. So the question is why would someone get worse? And this is such a fundamental concept in providing services for people with brain injury. And at the end of the day, the ultimate paradox is that you can't see someone's brain, but yet their brain lives in the world, and it is all of those contextual factors that influence the course of recovery. But that's what we're going to talk about here. So let's talk about brain injury as a biopsychosocial condition, and our assessment is modeled after the idea that it is a biopsychosocial injury, so that we can capture the holistic, if you will, or the global variables that are going to determine and influence vocational outcome. So if we start, so those of you who've been on this before are probably sleeping already, but we're going to start off with the donut and the hole, and this is the donut, and this is your pre-injury resources, and I've got psychological or cognitive resources. Some of us have great coping skills, some of us have some challenges in that way, some of us have got great intellectual and cognitive resources for some things, but maybe not for others, but that's just who we are. And then you place an injury, or the hole, if you will, in the donut, and that injury may be mild or it may be severe. It may cause language problems, or it may cause memory problems. And of course, as you guys know, that's different for each person. So those are going to be either transient or they're going to be permanent. In the case of concussion, a mild TBI, maybe they'll be fine in 2 months, and On the other hand, maybe it's a severe injury and those will be permanent difficulties. Ultimately, then, as that person starts to become aware of how they are functioning and the impact of their impairments, which typically happens when they leave the hospital, then that's when the most critical period is. So from us, now we've talked about the biological side of this. So we're talking about brain and impairments. And as you'll see in a minute, that's the basis for when we think about medical model interventions, as opposed to social or vocational interventions. But as this period of awareness emerges, then patients either start to continue to recover, or they start to deteriorate. So let's take the case where now the person develops a depression, they develop a post-traumatic stress disorder, or they have anxiety. What is the impact of that depression on their biological functioning, on their cognitive functioning? Well, of course, as you know, that's likely to be harmful to that. So on the other hand, if they have excellent coping resources and they have excellent environmental supports, or they get proactive follow-up and treatment, then we may prevent those comorbidities from occurring. And so in the next level, now we're at the social level of this. We talked about the biological in the center, we talked about the psychological and cognitive in the middle. Now we're going to talk about the social level. So what happens when people get depressed, of course, or they're embarrassed or ashamed about their impairments, they withdraw from friendships, and they become irritable and argumentative, and they test relationships. Particularly, and then what happens if you have lack of support in your family, or lack of friendships or other social supports that you rely on, versus the person who's got then supportive family with good community integration. Their employer wants them back, as an example. Now we've got two very different trajectories going. In one case where the person is likely to continue to recover, but on the other case, the possibility that that patient may show some decline, like we saw in the previous figure. So in the best scenario now, if we prevent those comorbidities and they've got good social support, that helps that patient adapt, if you will, and that's the key word, which lessens the effect of potentially the very same injury in a different person's brain, in a different person's environment. And now that patient may deteriorate, which increases the relative effect of the very same injury. So we get two totally different outcomes in two totally different people with the same injury, which is what makes this injury so complex, and one of the reasons that our outcomes have historically not been good. So the barriers to employment, have always been in this population: the cognitive and behavioral impairments, the gaps in our services between medical and rehabilitative and vocational services. The obstacles to a continuum include different organizations, different funding mechanisms, lack of awareness of services, and not enough brain injury expertise out throughout the entire state. So this kind of sets the stage for, okay, what is the nature of this injury? Well, it's a biopsychosocial injury. It's a biopsychosocial disorder, and an effective continuum from medical to return to work has to address those different levels of recovery. The other issue is that at least in moderate to severe head injury, brain injury is a chronic condition. Most of the time we think about brain injury as an event from which you recover. And conceptually, the problem, that's I'm afraid to say, perhaps wishful thinking, at least for a significant portion of our folks with moderate to severe injury. So the truth is, and there was a whole journal that came out on this in a journal called the Brain Injury Professional. And if anybody wants to have a reference to that, let me know. I'll get it to you. But the truth is that yes, brain injury starts as an event unlike diabetes, for example, which doesn't start with an event. It starts with this insidious climb in your blood sugars. But we recognize diabetes as a chronic condition. But brain injury is a chronic condition that has, unfortunately, an abrupt onset. And so I think this conceptually changes how we think about the types of interventions and how we organize our healthcare and social systems long term. So why is brain injury a chronic condition? Well, those of you that have been TBI specialists for a while know this perfectly well. These folks have higher risk factors for both medical and psychosocial difficulties. And so they're at risk for late onset. In fact, they're at risk for late onset diabetes. Brain injury can interrupt the pituitary hypothalamic axis that can result in diabetes insipidus. You can have post-traumatic seizures that have late onset. It's unusual, but it certainly happens. Chronic vulnerability to psychiatric and psychological disorders is present after a brain injury. We all know what the vulnerability is to self-medication with substance abuse. Traumatic brain injury is a risk factor for premature cognitive decline, as we've seen in some of our football players, unfortunately, for traumatic encephalopathy. And it's a risk factor for family instability. And these are just some of the vulnerabilities that this population brings to bear. So what does that mean for their vocational stability? What does that mean for vocational placement? You may spend 6 months working with someone to get them back to work, and they have a new onset seizure disorder. That really obviously changes your vocational plan. Or the other issue is that their parent dies, whom with they've been living, or they develop a serious depression. All of that will influence their vocational placement, and it'll threaten their vocational stability. So we need to think about what we're doing with this population as not disease management, but rather, as you would say in diabetes, but rather as condition management, which is a different sort of paradigm, and that's why resource facilitation is structured as it is. Now, the World Health Organization developed some general principles for chronic disease management that I think are just as applicable to brain injury as they are anything else. The first issue is to develop a treatment partnership, which is, of course, what happens between the resource facilitator and the patient and the family. The focus is on the patient's concerns and priorities. You use the 5 A's: assess, advise, agree, assist, and arrange, which is, I think, probably not different than how you as vocational rehabilitation counselors set up your evaluation and relationship with your patients. A goal is decidedly promoting self-management. Again, just like we do in diabetes, we try and teach people how to monitor their blood glucose levels and how to manage their medications. The same is true for mood. The same is true for irritability. The same is true for memory. The same is true for initiation following brain injury, and that is to try to promote as much as possible their self-management of the condition. And this is, I think, organized a proactive follow-up. So we know that the behaviors that people need to demonstrate to manage a chronic condition probably doesn't exist in their behavioral skills or repertoire before the injury. So now we're asking them to do something they've never had to do before. So proactive follow-up is a way to help them learn, remember, and establish patterns of behavior to manage their own behavior. involving expert patients or peer educators. So this is, of course, why we try to get everyone to the support groups of the Brain Injury Association of Indiana, because these folks can be very powerful and extremely helpful. The other thing is that some of our staff have been caregivers of folks with brain injury, and so clearly they may not be expert patients, but they're expert caregivers in terms of how it is to follow up with these folks. And then linked to community-based supports and resources. So again, the World Health Organization, I think, really provides a structure for this and how we've designed resource facilitation. The next point is to use written information, that is like registers or digital tools, iPhone apps, to help them learn to document, monitor, and remind. So if you don't remember to use your insulin, or you're not routinely checking your insulin, or you don't have tools to do that, then that's a problem. If you don't have tools to monitor your mood or to keep track of your sleep, let's use sleep as an example. That sleep turns out to be such a frequent problem in return to work after brain injury, because such a high percentage of our patients have sleep disorders as a consequence of their injury. So then they have daytime somnolence or fatigue, then which makes it difficult for them to get engaged vocationally. And then, of course, work as a team, which we all do and or aspire to do and try to do. And then lastly, to assure continuity of care. So, and we still have a very long ways to go, of course, in this issue, in terms of connecting healthcare systems with social support systems and social agencies and long-term supports. There are still way too many gaps, fortunately narrowing with what we're all collectively doing in resource facilitation. So that's what I wanted to do, is to just talk about the brain injury as a chronic condition, if you will, and what are the implications there for how we assess and how we intervene with folks with brain injury in resource facilitation. There are also different levels of assessment and intervention. So to use one model that helps with that in some respect is the distinction between a medical model versus a social model. So of course, when we think about the medical model, we think about trying to assess impairments. And in brain injury, we could talk about cognitive impairment, or we could talk about depression, or we could talk about hemiparesis, or we could talk about balance disturbances or sleep disturbances. And then we're going to give them a medication, or we're going to give them some rehabilitation of some kind that's targeting that impairment, or we're going to use a device to help with that impairment in some way. And so that flows logically out of the medical model. But there's a social model, and in fact, actually, there's more than this, and we'll get into it in a minute. But in resource facilitation, we've got to assess beyond the medical model, and that is into the social model. And now we need to think about the entire individual's functioning, a holistic view of them, if you will, and the social context in which they exist. So back to the model I showed you of the biopsychosocial, it's in the assessment process, we need to look at those cognitive factors we know that influence return to work, those behavioral factors that we know influence return to work, or psychological factors. But we also need to look at their family support systems. We need to look at their transportation, their access to natural supports in the community, whether or not they have a peer group that's a source of support, whether they have transportation, and the environment in which they exist. And of course, that's not traditionally at all a part of a medical model assessment. And I guess we would very much argue that they both, of course, have significant value. And part of the problem is that not only is there a gap between our systems, but there's a conceptual difference between our systems, and that is that the medical model of course, emanates from the healthcare system, and a more social model emanates from our social agencies. And so the gap is, in a way, made worse by the fact that we have these two different approaches to things. The World Health Organization also provided a different model that even helps us more in terms of how we should assess these folks. It's called the International Classification of Functioning Disability and Health. And it's interesting because in Europe, particularly in Germany and Scandinavia, their governments have mandated that rehabilitation services from all sectors be organized around this model, interestingly. So let's take a look at this. So in the middle, I'm going to start here in the middle, and we're going to start off with kind of the medical model stuff. So here's impairments, so bodily functions and structures. So an example of that would be a visual field deficit, a hemiparesis, and aphasia. So you have this impairment in language function, as an example. So then that causes some kind of impact on your activities. So now you may have difficulties with communication, for example, or you may have difficulties riding your bicycle because of hemiparesis, which then that change in activities has an impact on your participation. And participation is defined, obviously, as your ability to resume roles and activities that you once had. So if my role is to be a neuropsychologist and I've got aphasia, then obviously that aphasia is going to affect participation in my work activity. So there's this direct relationship between biology and impairments, activity or functional levels of activity and limitations, and participation or restrictions like vocational, or we could also talk about recreational activity. And when we talk about participation, maybe it's my bicycle racing, or maybe it's who knows what, canoeing, or whatever I like to do recreationally. Or maybe my ability to function as a parent, which is another role that I have. So those are the kind of the core dimensions, and when we assess someone, we have to think about them at all three of those levels to get a comprehensive medical and social perspective of how that individual is functioning and how that relates to return to work. So at the top of this now, we've got, their particular health condition. And of course we know that's a traumatic brain injury, but now we can understand the variability and the heterogeneity of this course of recovery even more, because the primary diagnosis may be a traumatic brain injury. But what if 6 months later now we have a new health condition like depression? Then that depression modulates or influences all three of these. It influences their dopamine levels in their brain, that influences their activity levels, and that influences their participation. Conversely, when you treat that depression, then the good news is you have a positive impact on their memory. You have a positive impact on their ability to perform activities of daily living, and it has an impact on their ability to return to work. So let's come down now on the bottom side of this and say, okay, well, there are contextual factors, and we called them social factors in the previous model. But these people, all of us live in a world. We live in a family, we live in a suburb, we live in a community, we live on the farm, wherever it is we live. And there are also personal factors that mitigate this. So aging is an example of personal factors, or pre-existing conditions that may influence that. Environmental factors we've already talked about. My best friend happens to be a drug dealer, unfortunately, and so therefore I have too easy access to drugs that influence my recovery, as an example. Or I have a family that takes me to absolutely every brain injury support group that exists so that I can have as much interaction or stimulation as I can. So this model provides really a conceptual basis and a larger framework that drives our assessment and intervention process. So if there are any questions on that, please just fire them out. Here's a real case example, if you will. So the disorder may be a traumatic brain injury with a right frontal subdural hematoma. The impaired function then is impaired memory and affective dysregulation. That affects, in terms of activities then, their communication and higher level activities of daily living, like managing their money or organizing their shopping and food preparation. And that, of course, then affects their participation because their memory doesn't allow them to return to work, and that causes marital stress because they're not serving in the same role that they were in their relationship. And now they've got environmental factors of no insurance, and they got a previous history of depression. So that example right there is exactly what, if you were sitting in our initial case conference, is kind of the scope of what we get out of the assessment. And so, of course, what that does is lay the basis for then recommendations of, do we do biologically oriented interventions? Does this person need an antidepressant? Do they need to see a physician for possible diabetes insipidus secondary to their injury? Do they need cognitive rehabilitation because of their memory disorder? Do they need devices to help with physical or sensory impairments? Can they be more independent with their activities of daily living? How is that? What do they need to return to work in terms of cognitive or behavioral or medical interventions that all result in that outcome? How do we manage their depression, and how does that affect their return to work? And how is their prognosis for return to work enhanced by treating that depression? Those are all kind of dimensions that are required in brain injury. So it's not a simple matter, as you see. It's a comprehensive model, and that's why we go through the various stages of assessment that we do. But I also think that's probably one of the reasons that we're being successful with getting these folks back to work. So some caveats. The relationship between impairments, activities, and limitations, as you saw earlier, are nonlinear. You never know. I mean, so something always happens. It's better to predict that something will happen. Their wife will leave them. The boss will decide 3 months later, gee, it wasn't a good idea. All kinds of, it happens in our lives, let alone not just to people with brain injury. The other thing is that mild impairments can result in significant limitations in activities or participation just as much as severe impairments can. So if I have a mild impairment of executive functions and I have now difficulties with planning, organizing, problem solving, that could be pretty threatening to my role as a neuropsychologist, and in fact could be hugely disabling. On the other hand, if those cognitive skills aren't necessarily part of what's required of me on a vocational basis, then that mild impairment may not have a direct relationship necessarily to my vocational placement and rehabilitation. Conversely, significant impairments can also result in relatively few limitations in activity or participation. So I could lose my left arm, and while I'm not thrilled about that concept, I could probably learn to be pretty independent in my activities of daily living and my roles, despite the absence of my left arm. Now, if it's my right arm, that's another issue, but I think you get my point. So again, it requires not only a global or holistic assessment, if you will, but it requires an analysis of the relationship of those impairments to activity and participation in that individual. So when we're doing our initial conference, those are factors we're taking into account, and therefore that leads us to generate the targets for intervention or the recommendations for interventions based on those data. So I want to kind of lay that framework for you, so when we talk about the assessment, you know why we're doing it in the way we are. I should say one other thing, and that is, we also did a review of literature looking at all the predictors of return to work following brain injury. So we wanted to make sure that we were using the science, if you will, to help us drive this. So of course, as you'd expect, all of the things like substance abuse, severity of cognitive impairments, especially severity of behavioral impairment, and so forth, things like that from the literature were incorporated into our evaluation process. So, someone please send your comments, questions in at any time. Okay, great. Yeah, please. Thank you, Laurel. So please do that, because I'm just mouthing along here, and am happy to shift. So as you know, there are 3 stages of service and resource facilitation, we're going to shift here a second, and Laura's going to go for a little bit.
All righty. I'm gonna scoot my chair over. I'm sorry for the pause here. Here we go. So, since I've learned that there's probably just a few of you that are brand new in the process, many of you know that in our initial evaluation, the resource facilitator will make the contact with the client and go into their home or a community location in their community and have a personal meeting to gather a great deal of information about how that client is currently functioning, what their support systems are, what resources do they already have access to, what resources do they not have access to, and so on. Then our local support network leader will participate in this process by sitting down at the conference and begin to gather resources that might meet some of those needs, regional resources that will meet that person's need or the family member's needs. Then the individual will participate in the neurovocational evaluation by having a consultation with the neuropsychologist first, and then moving through some testing materials that are designed. There's a core battery of materials that the person will take, but then there's additional assessments that are included to meet that person's needs. So not only is there a core battery, but our neuropsychologist will tailor it to that individual as well by adding additional components to the evaluation. All of this is brought together in a team meeting where all of the participants will sit down and generate a plan, and we are very fortunate to often have counselors join us on those conference calls when we sit together and generate the plan. Please know that you're welcome anytime, and our resource facilitators will send you a schedule of when we hope to do those conferences. You can also write me at any time and ask about a particular client. At the present time, I'm the one who's arranging those conferences. We love your participation. I think you often have materials that we don't have access to and information that helps us generate an even more comprehensive plan. So that's a very quick summary of the first stage, and then I believe often what's happening is that the VRBI specialist is sitting down with the client and the resource facilitator and reviewing the results of the NVE and the recommendations, and I believe then that the individualized program plan for employment is written and signed by the consumer, and should the VR counselor feel ready to launch into the next step, resource facilitation services are initiated. I know that Dr. Trexler is going to spend a little bit more time talking about that, so I'm not going to go into a lot of detail. Those services can last anywhere from 2 months to 9 months or more. up until the point of resource facilitation placement. And there are activities that occur then where the resource facilitator will pass over to the local support network leader many of the responsibilities then of being in touch with the employer and the employment services agency to make sure that everything is going smoothly at that stage of the game. So I was offering him a brief drink break and just wanted to give you this overview. I'm going to turn it back over to Dr. Trexler.
Oh, thank you, Laura. It was not a martini straight up, unfortunately, but it was nonetheless refreshing. So those are the three stages of service. I think most of you know our eligibility criteria. They're really very simple. And if you have questions about whether someone meets those criteria, just fire us an email or give us a call. Non-progressive brain injury, and a goal of return to employment or school that will lead to competitive employment. So yeah, Laura started into the resource facilitation intake, and here are some specific elements of that. I think one of the advantages of doing this in their home or in the community is, of course, you gather more data than if they come into the office. And I think that even though we end up putting a lot of miles on to do this, the face-to-face evaluation in their home and or community, I think, has been very helpful. Education's got to start right then, and that's obviously for the patient and the family. And then we'll get into some detailed history, and all of these items go into the resource facilitator's intake. So before they even walk into the team conference, we've got all of that data available to us, to starting to fill in all the gaps there that we previously discussed. And of course, they've got to get releases. So then we also like to use some objective metrics. And the reason we like objective metrics is because just like we did in our initial research, we're very committed to outcome measurement and program evaluation. So to do that on an ongoing basis, we need objective measures to track progress through the various stages of treatment. So every patient goes into our database, and we treat that data and the process just as we would if it were a formal research design, so that we can continuously monitor not only quality assurance variables like how long does it take us to get the patient from referral to intake or intake into resource facilitation services, or how long does it take to get to placement. All of those data, and I think there are several hundred variables in our database on this that we maintain on each patient, and from which we can easily do report generation to look at quality assurance and outcomes. So for example, as you probably know, part of our model is that the resource facilitator needs to have contact with that patient every 2 weeks for a variety of reasons. And so as a quality assurance measure, we can look at those data in our database and see exactly when all of that has transpired. But in terms of these measures, we use something called the Activities of Daily Living questionnaire, and that's not surprising because, as you saw in the World Health Organization, we have impairments, we have activities, and we have participation. Well, what you'll see is that we have measures of all of those objective measures as part of our outcomes measurement strategy. So we have this Activities of Daily Living questionnaire. We have the Mayo Portland Adaptability Inventory, which I'll show you in a minute. A survey of unmet needs and services. This is a very cool instrument. We have a very basic measure called the cognitive log, which is just a real basic fundamental measurement of their cognitive functions. and then we have the vocational independence scale. And all of these have been developed for use in brain injury, so they're specific to this population, which is, of course, a huge advantage in having meaningful, valid, and reliable data for this population. So let's take a look at the activities of daily living scale. This is an instrument that is rated by the patient, sometimes with family assistance if their awareness is not very good. The domains that we look at, of course, are self-care, household care, employment and recreation, shopping and money management, travel and communication. So it may be, then these may be hugely important for vocational placement, and they may not be as important for vocational placement, depending on the individual. Each one of these domains is then scored as percent disabled. So a person could be 5% disabled for self-care activities, but 70%, for example, for employment and recreation. This instrument takes about 10 minutes to 15 minutes to complete, depending on, again, the awareness of the participant. And if any of you want to see this scale, just, again, send us an email. And then we get a total disability score. We're also interested in this variable, of course, as a predictor. As we aggregate more and more data, does this predict return to work? It hasn't shown up, interestingly, in the literature because no one has looked at that relationship directly. But we're going to continue to gather those data as it relates to individual care plans, and then also as an aggregate or as a group. So then the next instrument that I mentioned was the Mayo Portland Adaptability Inventory. This is an instrument that was developed especially for brain injury in the outpatient chronic phase. It was developed by a colleague of Laura and mine, Dr. Jim Malik, who's our Director of Research at the Rehabilitation Hospital of Indiana now. He did this when he was at Mayo, though, at Mayo Clinic. And the Portland comes from the first version of this test was developed by a neuropsychologist by the name of Muriel Lezak out in Portland, Oregon. And then Dr. Malik modified it when he was at Mayo, and now it's probably one of the most widely used measures in brain injury throughout the country. So it's a measure of disability of a slightly different type from what you saw before. It is a measure of disability. So in this case, lower scores are better. So as you might see from this example over here, down here is no limitations, mild limitations, mild to moderate, moderate to severe, and severe limitations. There are 3 different forms of this that we use, depending on the situation. It can be completed by the individual with the injury, it can be completed by family members, and it can be completed by professionals working with the patient. There are 3 different subtests that have to do with domains particularly important for brain injury. The first issue is abilities. This subtest measures abilities like mobility, your ability to get around, your memory, your hearing and your vision, as an example. The next subtest is a measure of adjustment. So it includes things, of course, like depression or anxiety, or how your family situation is, and how it is that you are doing with friends and social with friends. The next subtest has to do then with participation, again mapping over the International Classification Function. So participation, of course, includes things like, are you able to go into the community and do your own banking? Are you able to return to work? Are you able to volunteer? Are you able to drive? So are you engaged in social activities? or recreational activities, and then a total score. So what's the beauty of this is then we get, and this is an actual case example over here. So in this case, it's interesting because the person was showing not so much disability with respect to abilities. I mean, basic memory, impairment level stuff was only mildly disabled. Again, showing the nonlinear relationship amongst these variables. On adjustment, this patient was close to severely disabled. So now we know that this person's having a lot of psychosocial difficulties that are much more likely to affect return to work than it is difficulties with the original impairments associated with the injury. Despite this level of difficulties with psychosocial adjustment, this individual was participating a little bit more than would be predicted based on his level of adjustment, difficulties with adjustment, but he's having more difficulties with participation than would be based on his level of difficulties with abilities. So this gives us really critical data about where do we need to set resource facilitation targets, and how do we measure that over time to ensure that we're getting this person more capable and more ready for a return to work, and to how to promote and retain that stability once we get it. So any questions about the Mayo Portland, please let me know. The next instrument that we use, it's an objective measure of this measure of unmet needs and services, and this was developed by a brain injury researcher at the Rehabilitation Institute of Chicago. And it's a very simple idea, and that is to ask people what they think they need and give them some structure for helping them identify what those needs are, because of course most of our patients and their families can't identify their needs because they don't know that resources even exist in many cases. So it's got two components to it. On the left-hand side of the page is a notation about that they receive help now or have within the last 12 months for this kind of need. So let's say, and there are 27 items on this questionnaire. So as an example of the item might be traveling in my community. So on the left-hand side, they put a number in, or they check whether they have received help for that activity in the past. Maybe it's traveling in their community. And on the right-hand side of the form over here is a place for them to check if they need or want help with that item, like traveling in their community. Other examples of items, as I said, there are 27 of them, but other examples include improving job skills or improving their memory, controlling my temper, obtaining equipment, feeling part of the community, et cetera, et cetera. So this gives us a very good idea of the patient and family's perception of what they need. And of course, as you noted in the World Health Organization model for disease management, it should be patient-focused. It should be client-focused. We need to address, especially at this level of recovery, what the patient and family perceives are critical issues as related to managing their condition. So that's a hugely important data set that spans both a bio as well as a psycho as well as a social model of assessment. So then we also, and this is again done out in the field by the resource facilitator, we do a quick assessment of basic cognitive functioning called the C-log or the cognitive log, and this was developed by a neuropsychologist down at in Alabama, at the University of Alabama. And what we needed was a test you could do in 5 or 10 minutes that would give a reliable and valid estimate of the severity of overall cognitive impairment. And so it's only 10 items, and it focuses mostly on memory and executive functions. So examples in this test would be you read the patient a name and an address as if they were going to address a letter, and you ask them to repeat that from immediate recall or immediate memory, and then you come back 15 minutes later and ask them to again recall that name and address. Another test is you ask the patient to repeat the months of the year backwards as quickly as they can. And so that's a measure of what we call working memory or controlled attentional processing. It's very much related to frontal lobe function as another example. And then there are some items of what we call response inhibition, that is, the ability to which the patient can not respond. So sometimes, of course, as you know, our patients have trouble with impulsivity or with perseverating, that is, repeating something over and over again. But sometimes in our life, of course, we need to inhibit responses. So there's a couple of very clever little ways in there that we test for that. And that gives a score. The cognitive, the C-log gives a score that's quite analogous to an overall IQ. It's a very basic estimate of cognitive functioning, but nonetheless, that way, when the resource facilitator has completed that, we can begin to plan for the more complex in-clinic assessment when they come in, and some idea of how many difficulties that person may be having. So those are some of the objective measure. Although sorry, there's one more, and then of course the vocational independence scale. So the vocational independence scale is an instrument that again was developed by our colleague Dr. Malik when he was at Mayo, and then I've modified this scale to serve resource facilitation a bit more. So we've got 6 levels of vocational independence on this scale, and you can see there the levels of definition. It has to do essentially with 2 criteria, and that is the amount of support someone receives, as well as how much time and the level of that employment. So we obviously go from unemployed to sheltered to community-based with permanent supports, with temporary supports, and then an issue of less than 15 hours or more than 15 hours but less than 30. And so we have a way to classify with some defined criteria exactly what outcomes are. So this is the vocational independence scale that we use obviously in our database as well as for measuring outcomes. So Laura mentioned the local support network community assessment, I think. Here's just some brief treatment of that. The main issue there is regional community resources, and in the case of, and especially with respect to employment opportunities and natural supports that exist in that community. And as we've served more and more people, it's remarkable the variability, but also the importance and the strength of some of those resources that are available out there that you would never know about, that never exist on a website, but they're out there, and it's the local support network leaders are constantly gaining new information about that. The local support network leaders also have or are developing advisory councils to try to build capacity of communities and to improve networking and communication across resources. And of course they coordinate with the resource facilitator as they're providing services to a particular client as it relates to community resources and all of the above. So those are critical components of what their engagement is in this. So now the patient the client comes to Indianapolis for this one-day evaluation. I will tell you that we're not too far away, I don't think, from having telehealth models to be able to do this over the World Wide Web. Hopefully by the beginning of the year, some of our patients that can't make it to Indianapolis will be able to do this over the web. So yeah, so I think I see we have a couple of questions here. This is terrific. Okay, TBI 2.
Me.
Oh, that's you. Okay. Okay. So for example, in this okay. So yeah, maybe can you just read the question? I'm sure I get it.
I don't have it all on my screen anymore, but here we go. I was just raising the question when it fits into your presentation, and I know you'll be talking more about the report. Sometimes there's specific recommendations in the report. For example, comments like we might train a client on how to do the goal, plan, do, review strategy to help them with organization and executive skills. My question, because I think I've heard this from some of the VR people, who knows how to do these types of trainings? Where does VR and the RF and the LSN team send their clients for these trainings? Where do these training suggestions come from, etc.?
Okay, great, thank you. So yeah, so what you're seeing in the reports now, those are recommendations that are occurring at a impairment level. So in this case, like the goal, plan, do, review, that's a particular cognitive rehabilitation strategy that is in the research, and it's also been demonstrated over multiple studies to have good efficacy and good effectiveness. Goal, plan, do, review is a cognitive rehabilitation strategy to help with executive functions and planning and organizing one's behavior, which of course so many of our patients have difficulties with. And so anyone that's trained in evidence-based cognitive rehabilitation can provide that service. It's in so Ed Haskins and I and Rebecca Eberly at some of you know Rebecca at Indiana University in Bloomington in the speech department, and then two other collaborators from New York, and one other from New Jersey. The seven of us worked with the American Congress of Rehabilitation Medicine to develop a cognitive rehabilitation manual based on the research. So it's a guide for therapists in terms of how to do evidence-based cognitive rehabilitation. And so, you know, so yeah, the people of course at RHI have been trained on this, and we're going to be doing a workshop, a 2-day workshop here in Indianapolis. The American Congress of Rehabilitation Medicine is going to be doing a 2-day workshop for therapists in Indiana in May of next year. So I'm hopeful to get therapists, as many therapists from throughout the state at that workshop as possible, because I think the very vast majority of our therapists in Indiana have not been trained on evidence-based cognitive rehabilitation, and given that so many of our patients have those kind of impairments, it'd be nice to see capacity throughout the state, or better capacity throughout the state to address those issues. So I don't know if that's...
Yes, thank you. Thank you, Dr. Trexler. We do have two other questions that popped up.
Yeah, okay. So Shell, hi Shell, thank you as always for being here. Of the measures you use at the intake, they are absolutely all useful for determining progress. They are all repeated at case closure, so that we have pre-post assessments, objective assessments of outcome. That's absolutely correct, and that's hugely important. And that's what we'll be reporting to you in the future, is the outcomes based on those measures. And sometimes we'll re-administer them in the course of resource facilitation, because we want to check to see if there's been any change on any of those instruments. So yeah, that's exactly why they're there. It's not only for the initial assessment, but for discharge and follow-up. Thank you, Shell. And then Alan has a question. Why might it be helpful for a client to receive an NVE when they had an earlier neuropsychological evaluation? I don't think I put, let me see if I put a, yes, okay, so I'm going to, Alan, I'm going to answer that in 3 minutes, because I've got a particular slide on that. Thank you for the question. It's an important question. So the person that, at least at the moment, comes into Indianapolis to RHI for a one-day assessment. As some of you know, if they come for more than 2 hours, we provide a hotel room for the night before for them, and I think a like $50 voucher for food, or $25 per person for the person, and we really like family members to be a part of that. So they come in and they start off their day by seeing a neuropsychologist, such as myself or Dr. Ed Haskins or Dr. Summer Ibarra. And what we'll do, first of all, of course, is take a look at the intake provided by the resource facilitator, all the measures that they collected. We'll gather data from the local support network, leader assessment of community-related resources, etc. We also take a look at any medical records that we've been able to lay our hands on, and that drives that interview in terms of what we focus on. Then we'll ask to have a number of tests performed that span the scope of these different models we've discussed. So there are measures of cognitive functioning, of psychological functioning, and vocational assessments, coping skills assessments, etc. So that, Alan, I'm going to go to your question now. So it's not a traditional neuropsychological examination because the traditional neuropsychological exam was developed basically to be a diagnostic instrument. Yes, it describes impairments, but the traditional neuropsychological examination was developed to, for example, differentiate between, let's say, depression and dementia. You have a patient that's complaining of memory impairment, and the referring physician wants to know, are they depressed or are they showing signs of early dementia? Or it may be the case that they've had a concussion and they want to know, has this patient really got cognitive impairments associated with that concussion, or is it because they now have an anxiety disorder and that's causing problems with concentration? So the neuropsychological evaluation was developed to perform differential diagnosis. The scope of the testing there is limited to cognitive, sensory, motor, and very brain-based kinds of functioning. That is, it's entirely medical model. The testing is very rigorous in all of those domains, but it's rigorous because, you know, a referring physician is relying on us to make an accurate diagnosis. So we've got to make sure that we've got the rigor, reliability, and validity in that assessment process to come up with the right diagnosis. Now, the traditional neuropsychological exam can be used to determine eligibility for voc rehab services in terms of documenting the degree of impairment. So that is one utility of that process for resource facilitation. But in our patients that we have, the vast majority of the time, we know the diagnosis, and we know the significance of the diagnosis because of their disability. And so for, at least from a resource facilitation standpoint, we don't need a traditional neuropsychological examination. I can talk to them for an hour and know that they've got a disabling diagnosis associated with their brain injury. And So the primary focus of this process is on an assessment of vocational barriers and resources that is specific for people with a brain injury. So that's why in terms of the model, we needed to have measurements and strategies that were specific to this population. Yes, we do include a few components of cognitive functions like you might find in a traditional neuropsychological assessment. So yes, we do look at memory, of course. We do look at executive functions, probably not to the same depth that I would if I were doing a diagnostic neuropsychological examination, but I still want to find out how is their visual memory, how is their verbal memory, how is their problem solving, as an example. But then I ask a whole bunch of other questions that I wouldn't in a traditional diagnostic exam, and that is, what are their coping skill strategies? How do they do problem solving in social situations? These are different kinds of tests that tell us about what resources a person might need in the vocational placement process. How do they cope with ambiguity in a situation where they may not know how to solve the problem? Do they seek out information, or do they withdraw, as an example? And then we also do vocational preference testing, which we use a couple of different instruments that you're probably familiar with. The Strong is one of them. And so we'll get some objective assessment. We also get this test that I really like called the Vocational Barriers Inventory. And it's an assessment of the patient's perceived barriers. It's kind of like the unmet needs, but this one is more extensive and specifically focused on vocational outcome. We'll gather more data about their sources of social support. How is the family coping? What resources do they need? What kind of education or information? We'll gather information. We'll do testing on substance abuse as appropriate. We have a particular test we use in that respect. We'll look at, in more detail, what kind of options might there be related to transportation, or do the data look like this patient actually might be able to drive if they're not driving, and what resources would they need to get them independent in that respect. And at the same time, if you don't have it already, the resource facilitation evaluation can also be used to determine eligibility if you haven't made that eligibility determination already. So it's kind of a long answer to your question, Alan, but I hope that clarifies it. So again, what if the traditional eval was completed in the last 6 months? It doesn't really matter. Because so little of the testing that we're going to do during that day, relatively little of that's going to be redundant. Maybe some of it, but not a great deal of it. So furthermore, that allows us, if we have that data and we have those test results, that allows us to just ratchet down even further and gather information that we might not have the opportunity to do otherwise. So. Sandy's got a question. Hello, Sandy. Is there something that has been put together as the typical functional limitations by the type of TBI? Well, it's strange that you asked that question. Yeah, there is. That might be helpful to put typical issues into focus, right? So I've got just such a beast. I will send that to you, Sandy, and anyone else that wants it. Send me or Laura your email. In fact, it's set up, that's a very clever question, because it's set up so that it follows the model. That is, it's got impairments at the bottom, or it's got actually disease at the bottom, like traumatic brain injury, stroke, hypoxic encephalopathy, etc. And then right above that, it's got impairments, like physical impairments, cognitive impairments, neurobehavioral impairments. And then right above that, it's got activity limitations, so things like driving, things like returning to work or not returning to work, parenting, et cetera, et cetera. And then at the top, it's got participation-related stuff like recreation, return to work, and so forth. So literally with that form, you could circle each level and kind of create a map, if you will, of what's going on with each patient with that kind of guide. So yeah, I'll fire that out to you. Yeah.
So I have a question. Is that's related to the one-page document? That's what you're referring to?
Right.
Okay, and if anybody wants more extensive material, of course, there's things that have come out of the HRSA grants, like what to expect if someone has memory impairment, how that might show up in their behavioral presentation. There's also some really interesting things from the Job Accommodation Network where it talks about if someone has this in their documentation, this is what you might see and this is how you might accommodate on the job. So depending on what level of detail folks want, maybe you can let me know that and we can start sending more literature out electronically.
Thank you, Laura. Thank you, Sandy. Wendy, yes, Wendy's got a comment on there, yeah, about the LASH materials on brain injury. Yeah, so those are a fabulous number. I don't know, Wendy, I don't know how many we have, how many different flyers we have out there, but we've got, I don't know, 40 or 50 flyers about, as an example, irritability after a brain injury or depression after a brain injury, caregiving after a brain injury, memory problems after brain injury. There's a bazillion of them, and if any of you want information on those, just email Wendy at wendy.waldman at RHIN. Thank you, Wendy. There's our email. So then the critical questions from a vocational standpoint that we're doing, and as you can see, I hope from the outline, is what we're trying to do with this assessment, and I think it's a unique model, is to integrate the biopsychosocial nature of this condition, to look at it from a medical, from a social perspective at the same time, to look at it from the perspective of abilities, activities, and participation, because that's just the nature of brain injury, and that's what we have to do a good job of this. So the critical questions is what are the return to work or school options given all of the above? What are the options? Conversely, and what do we do? How do we remove barriers? Can we remove barriers? Are there barriers that are treatable? If those barriers can be treated that in a way that unlocks vocational potential, that's one issue. But if that patient isn't likely, if that barrier isn't likely to be able to be removed to a significant extent that's going to allow the vocational outcome that they want or that is possible, then what other alternatives or strategies are there? What strategies do we need to employ? What's realistic? And are those strategies biological? Are those strategies psychosocial? Are those strategies social? What are their vocational preferences and academic preferences if it's school issues? Because of course, what they want and what they perceive are their barriers are critical issues. And then, of course, what supports and resources are going to need to be organized, and in what sequence, which is a critical issue, in what sequence do we need to address those? So those are the critical questions that we address. And then we are going to discuss this in the initial team conference. And please, 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 if you can, join us, because every time I've been in one of these with you as a part of it, it's always been better than if you haven't been a part of it. So what we're going to do is identify their strengths and resources, and our report is organized like this in the summary. What are their strengths and resources? What are their barriers from a vocational standpoint? What's the vocational independence scale results at that time? What's their Mayo Portland? And we insert the graph in the report. what are the community resource strategies, what are the resource facilitation strategies, and then finally recommendations with more specific goals that are really for our team and ourselves in terms of what we want to get done first and by when, and what are later goals. So those are what you'll see in the summary at the end of our reports. So with that said, I was traveling down to Louisville yesterday, and I took a picture of Southern Indiana as I was going through there, and I thought that would be a good way to share with you that resource facilitation is coming to southwestern Indiana soon. The local support network leader is going to be Jean Kapler, who is also a social worker like Wendy. Jean has lots of brain injury experience and is going to be covering all the way down to Evansville. And that's exciting for us, and we're going to get her started here soon. The other thing is again, please send Laura or me topics you would like for future webinars. I think we have some planning already in that respect going. But we want to know your ideas. The other thing is we're not too terribly far away, I think, from getting our first newsletter out. And Laura, do you want to comment on the sections of the newsletter?
Oh, goodness. Off of memory, which is a fragile thing, I thank everyone for actually writing me back. I sent out an email blast a little while ago asking individuals, what would you like to see in a newsletter? And I was so pleasantly overwhelmed with how quick everyone responded and great ideas. From what I recall, we're going to give you updates on new staff members, how we're expanding. We're going to add in some data related to what are the numbers that we've served so far, what are the counties that we're serving up to date, how many people perhaps have already received the neurovocational evaluation, how many individuals are into RF Services Unit 1.
I know also I wanted a section in there on new outcome data, so that we're continually sharing that data. And I think we're going to do some case studies also.
We have one brief case study. I think that someone suggested that there be a section on terminology. Yeah. Maybe throw in a few words that are commonly seen in the neurovocational eval, but could use some defining and clarification.
Yeah, and I had hoped to address that issue today, but then after I got into the scope of this presentation, thought maybe we wouldn't have time, but I'm also happy to do that now if anyone has specific terminology questions. But yeah, so and if you would like, if you want that newsletter, so there also, I think there's going to be an announcement section in there too, Laura, about upcoming conferences and webinars and brain injury related stuff, support group stuff, and so forth. So yeah, I don't have that outline here in front of me. So yes, you're right, Denise. That doesn't look like the Louisville that you probably see, but you know, I was just trying to, as I was driving through, be creative in some sort of I was enhancing my experience as I was driving over your bridge. Cecilia, can you please let us know under what circumstances you would not recommend? So I think that we've not recommended resource facilitation services in a number of cases now. I think it often has to do, Cecilia, with severity. And it's, you know, we just hate to do this, but I think in both of these cases, we just saw no vocational outcome that's going to come out of it. And someday, hopefully in the state, we'll have resource facilitation services for outcomes other than vocational outcome. I'm thinking of two people in particular that I personally did not recommend. One of them was just severely impaired. She, unfortunately, is in kind of a chronic amnesia. That is, literally every minute is a new one for this patient, and or very close to that. And so I thought it was a very low probability. Another woman, kind of a similar story. A young woman who had a nasty hypoxic encephalopathy with just profound limitations of awareness and very significant cognitive impairment. And I think all of the king's men aren't gonna resolve those issues. And so I think severe psychiatric disturbance that would not be amenable to chronic psychiatric illness that would not be amenable to management. If it's manageable, then that's an entirely different story. But if healthcare professionals have been trying to get it managed for 3 years and it seems to be recalcitrant to management, then that could potentially be another reason. So I think that's my experience so far. Sandy, does that?
Cecilia.
Or Cecilia. I hope that answers at least my clinical experience so far. I don't know. Have you seen other cases, Laura, where we've declined?
Well, no, not to this point, but I just typed in what I've been hearing sometimes from the other side. I think some of the VR counselors have said, I think that there's probably a strong enough support system already in place for this person through the family, and RF might not be necessary. Sometimes the family wants to know that they have a team to help them, but certainly, between the VRC and the family, if they feel that there's adequate support, there's not a need to launch the RF services at that time.
Yeah, so sometimes you folks, of course, have awareness of issues that we don't, and so those are judgments that you may feel like that's the direction to go. So Shell, so you've got a question here. Current caseload, we feel like to get the outcomes that we did in our research trials, we want to maintain the same staff to same staff to client ratios. And so we feel like if someone is working full-time as a resource facilitator, they're going to cap at about a caseload of 40 clients.
Yeah, maybe 35.
Or 35 to 40.
Depending on how much travel.
Yeah, the travel is an issue.
And the complication of the case.
Yeah. So we're going to try to manage the service economically and qualitatively from that perspective. So.
Do you want to speak at all about how we're working for, we're seeking supplemental positions to assist us?
Oh yeah, so those of you in the northeast, actually anyone in the northeast or northwest or southwest, if you know of anyone who might be interested in resource facilitation positions, please let us know. We'll probably start them out as supplemental, which means part-time,
It actually means
or as needed hourly. But then we anticipate that those positions will quickly grow into full-time positions. So if you know of anyone, please let Laura know about that.
Actually, we have a posting on the RHI website this position is called a supplemental resource facilitator for Northwest Indiana and for Central Indiana. Those postings are already in place. And once we build some capacity in the southeast quadrant or area of the state, southwest, quadrant area of the state, then we'll be posting a position for a supplemental resource facilitator there, or part-time or full-time, depending on the need.
Yeah, thank you. So, with that, we have time for questions. We have time for terminology issues. We have time to go have adult beverages, or however you want to use the time. Yeah, please fire questions or comments to me if they are out there. I see, yeah, especially folks, the suggestions for future webinars, please let us know what you want to know. Because we can really tailor this to your needs. So I see that multiple attendees are typing. I would sing, but you really don't want me to while we wait. Okay, Shell, yeah, so can you share the current timeline for services in terms of seeing the client and receiving the report? Yeah, good question. So we are much better than we were right after the initial rollout. After the initial rollout, we had this bolus of referrals. And so I think we're getting closer to our expectation. Our expectation is that we get these out. Here, I'm gonna.
We like to say our gold standard, once we get all of our systems and processes in place, is to get the report to the VR counselor within 5 weeks. I think that it has been a little bit longer than that, especially in April and May. Our apologies for that. We're hiring at a fairly rapid rate to keep up with the flow, and we still can improve, that's for sure.
Thanks for the question, Shell. And Shell, you're always welcome to email, call us, and say, "Hey guys, I need the report quicker," or can you get this one to me, stat, or whatever. I think I was, I know I personally missed a couple of timelines by at least a week and maybe 2. So yeah. So you can yell at me, Shell. So. Okay, yeah, Wendy is, okay, thank you, Wendy. So our next webinar is scheduled for November 20, 2 to 4, and my initial thinking was to share with you folks what's going on now with our new HRSA grant with the Indiana Department of Corrections, so that you guys are aware of what's going on there. We're partnering with PACE here in Indianapolis and in Allen County. I forget who we're partnering with up there, but this is going to be to look at the effectiveness of providing resource facilitation to people coming out of the DOC in terms of not only helping them return to work, but to reduce recidivism as well. And so some of those patients I know already come to you, and so it'd be nice maybe in a way for you to be aware. We're helping the DOC learn how to screen for brain injury, just like Voc Rehab did 7 or 8 years ago, resulting in the whole concept of brain injury specialist in VR. So hopefully in the DOC 6 years from now, there'll be brain injury specialists there. Okay, and Wendy's sharing the leaders, so that are Lena Hackett. Lena Hackett is our partner in the project. with Community Solutions. Rihanna Edwards is Director of PACE here in Indianapolis, which is a reentry program for ex-offenders. And Susie Crane is one of our resource facilitators, of course. Okay, well, with that said, thank you very much for your attention. As always, you guys are fabulous. Please let us know what you need, and all the best, and have a great evening.